Good morning, everyone. My name is David and welcome to another of ACPP's webinars and the continuation of a regular set of PD opportunities that the college is running. Before we begin, I'd like to acknowledge the traditional custodians of the lands where my Australian-based colleagues are located today and pay my respects to their elders past, present and emerging, for they hold the memories, traditions, culture and hopes of Aboriginal and Torres Strait Islander people. In recognition that we are a binational college, I also take this opportunity to acknowledge the Maori as Tangata Whanaua and the Treaty of Waitangi Partners in Aotearoa, New Zealand. This evening, I have the pleasure to introduce you to our guest speaker, Mel Alexander. Mel is an experienced paramedic with over 20 years working in a variety of clinical roles around the world. Mel's professional history includes working as a paramedic and educator in Riyadh, Saudi Arabia, a registered nurse specialising in paediatric intensive care, an academic at Flinders University, and currently an intensive care and extended care paramedic working for the South Australian Ambulance Service. Mel is currently undertaking her Master of Advanced Clinical Practice Paramedic Practitioner through Deakin University and is passionate about the role that prescribing paramedic practitioners will play in our future. Mel has a passion for paramedic education, and today she will discuss her current role as an ECP for South Australia and the clinical and organisational structure of this position. At the end of her presentation, there will be a short Q&A. If you have any questions, please write them down into the comments section and I'll go through them as they appear, in the order that they appear. Without anything further, I'd like to pass the webinar on to Mel. Thanks, Mel.
Hi, everyone. Thanks for joining us tonight. Just quickly, I can't get it to, I've got the recording request on here and I just need to, it won't give me a mouse to get rid of that message.
Okay, is that blocking your screen, is it?
There we go. Now I can go back. Sorry about that. Okay. All right, now we're good. All right, I should have worked that out before. All right, so we'll get started. I've been working as an ECP for the last 4 years. It's been around since 2007, 2008, with the first group of 11 ECPs were employed by SAS. We're now supposed to have 43 of us. Unfortunately, we are terribly understaffed, as is everywhere in Australia in ambulance services in general. So as a prerequisite, you have to be an ICP with more than 2 years clinical experience as an ICP to be able to apply for the course. We do have one coming up very shortly, I believe in June, where we will have another, hopefully up to 8 people recruited into our program. We start with our didactic training component where we bring in our deputy CMO, CMO, doctors and other, wound specialists, community care specialists, palliative care, etc., into our training environment to bring as much education as possible. We then do some clinical placements and go out into the various community services that we do interact with a lot and get some exposure at their and see what their reality is like, followed by an on-road mentor internship and the whole thing is about 6 months. Our clinical governance structure is we are under, obviously, the normal SA Health clinical governance and SA Health. We work extremely closely with our CMO and deputy CMO. We pretty much have them on speed dial. Quite often, we will go to a job, we'll give them a call and go, this one's really out of the box, but I think we can keep it safely out of hospital if we do X, Y, Z. And we'll chat it through with them. And, if we're happy, we'll go ahead and try and keep the patient out of hospital. So the whole goal of the role of extended care paramedic in South Australia is safe hospital avoidance strategy. And we kind of also fall into a bit of a SPAC filler for SA Health role as well. So if something happens and SA Health are not really sure how to manage, like at the very beginning of COVID, managing people coming in off planes, they had no idea how to sort of set up some kind of testing structure. And so the ECP group actually worked closely with SA Health and we were the first ones to be doing the testing coming off airplanes, and we set up a nice structure there and then left them to it. So we quite often will get called in when people are not too sure how else to manage a situation. I think the benefit of being an AMBO in that situation is we like to ask forgiveness rather than permission. So we'll do what needs to be done and work out the rest of it later. So we also, because we are intensive care paramedics as well, we provide on road, when we're on road, we provide intensive care paramedic support to the crews, as well as fulfilling our ECP role and ECP workload, which can be challenging because one minute you're there, you know, happily guiding someone into the great beyond out of life in a palliative care setting, and then 10 minutes later you might be, you know, trying to pull someone back from the jaws of death and doing complex ICP stuff. So it's been a really interesting transition for me, particularly because, you know, as a paramedic and an IC, you know, you have that mindset of get in there, get things done, get them to hospital, you know, everything's a bit of a rush and a roar and a bit exciting and a bit fun and happy and whatever. But when you step into the ECP role, it's a completely different mindset that comes along with it, which I absolutely love. And, you know, I feel like I don't work a day in my life as a result of that. Because you have a completely different perspective on the whole situation. And sometimes that can be misinterpreted as, you know, being a bit slow on a job, but I'm actually just a little bit more thoughtful about things. There's a bigger picture that I'm considering. There's a whole heap of different pathways that we're thinking about in terms of how the patient is going to transition through their care journey and things like that. So we actually bring a lot more to any situation when we do go into even an intensive care paramedic backup role. There's a lot more that we're bringing to that situation, which is really beneficial. We also have a role up in our emergency operations centre, which I'll discuss a little bit more in a minute. But there has been, over the last few years, because of workload requirements, we've been pulled up quite often to take on a secondary triage role, as well as the OC clinician role, which can be a bit challenging in itself. So our on-role role is, as ECPs, is to keep people out of hospital using, you know, safe pathways if we can. We're still developing a lot of pathways, and COVID's actually been really helpful for that, because people are willing to take on board what we are trying to do and what we're trying to achieve with alternate care pathways. So we have quite an advanced and broad skill set that is ever expanding, and pretty much we can rock up to a job and have it be really left field. And as I said before, just have a chat with a deputy CMO and we'll come up with a way of managing that case then and there. So an example of that was I had a suprapubic catheter the other week that would not deflate. It was blocked, it needed to be changed, it wouldn't deflate. And rather than send this poor man to hospital from his nursing home bed, to have him then be isolated in his room for 2 weeks because he's left the facility, he wouldn't have been able to leave his room. We ended up using our ultrasound bladder scan, infiltrating around the stoma site with lignocaine and being able to pull quite hard and actually sight the balloon and pop it with a needle and deflate the balloon that way, and then retrieve it out and put a new one in. So, you know, and we've had other, you know, complex infections and things like that that we've been able to manage in conjunction with the CMO. For the most part, we work relatively independently and autonomously within our scope, but our scope's ever expanding. And if we come across something that is, you know, more significant than we might have dealt with previously, we do have that little lifeline that we can call upon within our CMO and deputy CMO. We still struggle with a lot of limitations due to legislation or lacking thereof, like prescribing and radiology pathways. We could actually keep a lot more patients out of hospital if we had a radiology pathway and prescribing rights. So that's an exciting sort of thing that I'm pursuing within both the Doctor of Advanced Clinical Practice that I'm studying at the moment and within my PhD that I'll be studying after that as well. So we've recently included the point of care ultrasound into our scope. We have it for bladder scanning at the moment, but there are quite a number of additional skills that we can use to expand our scope even further using that device. We are responsible for unscheduled care. So wound care, primary wounds, patients with chronic wounds that, not chronic wounds, apologies for this typo there. But yeah, if we have an issue with a chronic wound or an infection, a chest infection, gastro outbreaks in residential care facilities, beginning of COVID, we would also go in and try and support them to keep all their patients on site as much as possible and make sure that their infection control was up to scratch and that they understood how to implement the infection control necessary to contain an outbreak. We have a burns pathway, which is really, really groovy. We have a direct contact with the burns unit at the Royal Adelaide Hospital. So we will go to a patient who's got a burn that does need to be reviewed, but not necessarily right then and there in an ED and sit there all night in an ED. So we'll go assess, make sure all the primary treatment's been done. So your first aid, cooling of the burn, etc. We'll then take photos, send it through to the burns unit, and we'll give the plastics registrar a call, and we'll discuss the burn. We will put whatever burn dressing they would like. So if they want to put on a dressing that we've got, we'll use that. If they want something specific that we don't carry, we'll zip up, go and get it from them, come back to the job, put it on, give them their tetanus, book them in for their outpatients the following day, and they'll go in and go direct to outpatients and actually avoid the ED altogether, which is a really awesome pathway. We intervene with problematic pegs and catheters, predominantly in adults with the pegs, but we're starting to do quite a few more pediatric pegs as they come along. These little high-tech kids of ours that we've got in the community being managed by parents who manage to reef out their little, their Mickey pegs and things, we can just go and pop a new one in. And the BPSD interventions with residential care facilities. So if we have behavioural and psychiatric symptoms of dementia and their behaviour is escalating, we'll go in and review them, make sure it's not a UTI, make sure it's not an infection of some sort, make sure there's no pain, and look at all the contributing factors. And we can also bring in other services. Palliative care is one of our biggest areas of workload as well. Probably palliative care and catheters, wounds and pegs are probably our biggest workload at the moment. COVID has seen us have to intervene a lot more than we would previously because community teams are just not going out. So palliative care is one of probably my favourite area to be involved in, which sounds kind of weird, but I find it the most rewarding part of my job. I get a lot of currency out of being able to go in and support the family and educate the family in what to expect and just normalise the situation for them. It's one of probably my favourite case type out of that and maybe a good suture job. So yeah, so we're supposed to have 43 FTE across 4 teams working 24/7. Unfortunately, we quite often drop the road night shift from midnight till 7 a.m. If we're low on staff, because we have to favour staffing up in the communication centre to make sure there's 2 people up there between midnight and 7. So we have a day afternoon or a day night configuration. So we sort of rotate through those and we rotate between road and room. So for 2 rotations, we'll do day afternoon and then we'll do a day night. And then I think at the moment, because we're so short staffed, we're probably 50-50 up in comms and 50-50 out on road. But the hardest part is when we lose road capacity to make sure we're covering what's needed to be covered in comms. So, which none of us are happy about, but it's probably the least favourite part of my role is being up in there. But yeah, so in the month of March, we were dispatched to 438 events amongst so about 14 every 24 hours. There were quite a number of other cases that we could have gone to but didn't have the capacity to attend. And we have a treat, not transport. So that's basically how we clear a job, is that we've treated the patient, we're not transporting, and we've got a 74.4% strike rate for keeping people out of hospital overall. Some things are easier to keep out of hospital than others. Some things are just a little more complex. So Yeah. So we tend to go to a lot of gastros, back pain, wounds, catheters, infections, and just some general medical work this stuff out type stuff. So, and a lot of our referrals come from road crews, going to a job, finding a catheter case, or they'll go to a wound and think it's something that we might like to get our teeth sunk into, and they'll refer it through to us, which is awesome. It also helps keep those patients off the ramp. We are consistently, probably the most we get our catheters and wounds from crews on road. Some of that is they don't really understand the extent of what we can do and the scope of what we can do, because it's not defined. So we try and capture a lot of those cases if we can while they're still on the pending screen up in comms, and that way we can pick up a job that we think we can probably value add to, and we'll dispatch it to the road ECP. So the other unfortunate component of up in comms is the callback. So when we're not meeting our key performance indicator criteria for getting to a job on time, and timeframes are blowing out by hours, we will call the patient back and re-triage them using the Manchester triage tool as a way of just determining whether they can stay at the current priority. Are they well enough to scooch into a taxi and send to a priority care centre or some other urgent care centre? Or do we actually need to upgrade and get someone there yesterday? So yeah, there's a few different ways that we can manoeuvre a case, but you still need a car available to respond, which quite often we don't have. And in March, on average, we were doing 116 callbacks every 24 hours between three of us. It was horrendous, nothing short of horrendous. So, and we've had months that have been a lot higher than that as well, which is not ideal. But on average, we cancel between 15 and 20 cases a day. And over the month of March, I think we cancelled 538 jobs, which meant ambulance didn't have to go. Some of those, they're well enough to go. They need to go to ED because we've got no capacity to go to them, but they actually need a medical review, and we've popped them in a taxi, and that counts as a cancellation of resource, but it's kind of not really a hospital avoid as such. So continence care is one of our bigger areas. So we'll do unscheduled catheter changes. We push back to the normal provider of the patient if it's a scheduled or routine change. So we'll go if it's blocked. We go to we decided to do a trial avoid at 4 o'clock on a Friday afternoon. We thought that was a great idea. Let's do that. So we'll go and recatheterize, or we'll do a bladder scan and see whether that's actually necessary. We do go to a lot of hematuria and infections and dislodged or blocked suprapubic catheters. Quite often we'll be called as well if one of the community providers is not able to catheterize the patient for some reason. They've taken the old one out and for some reason can't get the new one in. And we'll also go to palliative care patients who are in opiate induced urinary retention. And the record, I think, I'm not quite the record holder anymore. Someone surpassed me the other day, but I did have one palliative care patient with 2,750 mils of urine in his bladder because he'd had a few days of not actually voiding, and they just assumed it was constipation, and it was not constipation, it was urinary retention. So yeah, that was the cause of his abdo pain. He was quite happy after that. So in terms of community provider support, we work across all of the regions. So we've got pretty much a global perspective on Adelaide when it comes to we've got some really fantastic we've got a residential care outreach team down south, and they are amazing, but the Jerry team out north not as amazing. And we work across all of the palliative care, central, north and south. North are just schmicky-doo. They are really on point. The others could learn a thing or two from north. And if they were all consistent, it would make our life a lot easier as well. So we have 24-hour access to the palliative care consultant on call. And we've just recently had a 24-hour on-call PAL care service start up where we can actually admit patients with unexpected decline to a palliative care service for end-of-life care. We've needed that because without prescribing rights, we can't go in and just get their end-of-life medication sorted for them and whatever without without having them involved. So it's actually helped us keep a few more unexpected declines out of hospital and hospice, and saving them from dying in an ED. The most common calls for PAL care are pain crises, or, you know, a symptom crisis, so nausea, pain, and bleeding tumours and things like that. So yeah, we'll go in and adjust end-of-life medications. We work quite closely with the PAL care teams to make sure the patient is as comfortable as possible for their end-of-life care. We work with a lot of the other community nursing teams to support them with their continence care where they can't get to them. We'll go to all catheters, but predominantly we do the males because we're trained, there's more of us trained in male catheterization, whereas not all catheter nurses with some of the community providers are trained. We'll go to hospital in the home. We've got a new program that started up just before COVID called My Home Hospital. They require a full medical workup for the patient to be admitted. They were getting those patients to go to an ED and then send them back home again, but they've just worked out that we can do that assessment for them with point of care, ISTAT bloods, etc. So we can do all the workup they need for them. So they're just cottoning on to we're available and would we like to work for them after hours as well as doing our normal job. And we work quite closely with the Metropolitan Referral Unit. So patients who need to, who are going to a hospital in home program, they can't get someone in time to deliver a medication or anything like that. We will quite often get called to go and recannulate or give medication or whatever until their service can get up and running and in routine with the patient. So we get to do some really, really groovy wound management. And this is my other favorite bit. So we've got at our disposal, we've got suture, glue, staples. We do the chronic wounds as well. If they need redressing, some of them are soaking through before their care providers can come back and do them. We go anything from a skin care to a skin tear right down to some really wicked deep blacks. The image you can see on the screen there is used with the permission of the patient's family. She was a palliative care lady, and she had a pretibial hematoma that she must have bumped it on something and it's just blown right up. And the crew were called to take her to hospital, and the clinician up in comms said, "Oh, go have a look and see." So we went and had a look, and I'm like, I reckon, and this is one of those out of the box ones, I reckon might just have a chat with the CMO. So I had a chat and I'm like, I reckon we can drain this and keep her here. So we did. And I went and followed her up the next day, and it looked pretty good. She died 2 or 3 days later. That was expected. But yeah, she didn't have to go to hospital and be caught up in the hospital system for that time, which was really nice. So yeah. So some of the stuff we see, this is the after. Oops, I'm just trying to work out how to just minimize you guys are all on my screen in the top corner there. So there we go. I think if I just click. So this is how it started. You know, we do get to play detective a lot. The thing with some of these stories we're told, this guy was in a residential care facility. He had quite a significant Parkinson's. There's no way he would be able to get himself up off the floor. I was told he must have had a fall, but it was unwitnessed, but there's no way he could have got himself up off the floor. Perhaps he smacked his head against a wall, door frame, something like that. But they said there was a piece of string caught around the ear, and that's how that happened. The string cut his ear. And I'm like, a piece of string is not actually going to fracture cartilage. So something's not quite right in the story there. So he had torn all the way through. I don't know if you can see my mouse. Yeah. There's a groovy way of being able to see a mouse, but no. But if you can see just on the inside, it's all lifted up and away. All the skin in the pinner has lifted up and away. And yeah, it looked pretty nasty. And I looked at that for quite some while. I have to say, I'm going, I'm just not sure where to start. It was quite a significant wound. I mean, they'd sedated him with his PRN medication so that he was nice and placid, and he was just chill in the bed, which was great. But I just was not too sure with this one where exactly I was going to start. As you can see down there, it's not the world's greatest photo, but you can see the cartilage in the center of the wound there. There we go. That one's a bit better. So yeah, and that's how we ended up We basically took a posterior approach first, put some nice big sutures in to hold the ear in shape, and then just went in and around to bring everything. It does look a little bit pointy, but when I went back about 10 days later to check on it, it actually was still a little bit cauliflower, but they'd done the right thing and kept the pressure bandage on every day in that time. And so it wasn't a big cauliflower ear. And unfortunately, a week later, he fell and did a NOF. So he was lost to follow up for me from that point on. I'm not sure what his outcome was post the NOF, but the ear looked really good at the end of it all. But yeah, it was a really good job. I actually had our deputy CMO, I gave him a call. I'm like, oh, Hugh, I'm just not sure on this one. I just think, should we send him off? And he goes, where are you? And I told him where I was. He goes, I'm not that far from there. Do you want me to come and have a look? So he came out, and that's the level of support we have from our CMO and deputy CMO. It's amazing. But they, Hugh came out and we looked at it together, and I'm like, yep, this is what I'm thinking. And he's like, yep, no worries. Do this first and that first. And I reckon it'll come together better. I'm like, okay, boss, let's go. And yeah, it was nice having someone pass me tools and hand me extra bits of suture and stuff. So that was really helpful. But yeah, it was great. So yeah, that was the other angle. Sorry, it's just all right. So the role we play coming back from wounds, when we're up in comms, it's multifaceted and it's always adapting. Unfortunately, it seems to be more and more stuff comes on us. We will give in-call support for the EMDSO staff on the O calls. So they've got a script they have to stick to, and if they go more than 11 words off script for the call, they fail on audit. And there's a lot of stuff they're not allowed to advise. So they'll send a runner to come down and get one of us. We'll go and plug into the call, and we'll intervene with additional first aid support for whatever's happening on the road or out in the world at the scene at the time. Some of them are probably a little sleep disruptive, the kind of calls that we deal with. And I honestly don't know how these EMDSOs can do this call after call after call after call. At least I get a break in between and I can go on to other things, and I get to go to some nice stuff in between. But yeah, some of the calls that I've had to jump in on have been rather horrendous. So we also are a decision support tool, so to speak, for the dispatchers when they're making decisions about, out of the 18 outstanding priority 2s we have, Mel, which one gets the ambulance? I've got one. Not a place you ever really want to find yourself, but it is somewhere we're finding ourselves more and more with our lack of resources. We're also clinical decision support for the crews on road. So if they need to extend outside their scope, they'll give us a call and we'll authorise that up to a point. And with some decision making, we'll involve the CMO and have a chat with them, and we have a 3-way conversation and come up with the best plan for the patient. We also get involved in the patients refusing against advice. Crews will give us a call and go, yeah, we want to leave this one home. They're ticking all these boxes. This one's okay. I'm like, yep, you can T&T that one. That's no worries. But, this one, we really want to go to hospital, but the patient won't go. We look through all the online clinical databases like EPAS, Sunrise, and Oasis that we have over here, and we'll check history, make sure there's no guardianship orders and all sorts of things like that, and make sure that the decision's being made, that the patient's got capacity to make that decision, and that if they don't, we can invoke some other measures to get them to hospital. If they do have capacity and they're refusing, then we have that discussion with the patient as well, quite often on the recorded line, so that the crew are actually protected in this rather litigious environment we're in at the moment, to make sure that they can have the safest decision for the patient. We work up and identify ECP cases, and we do the secondary triage calls as well. So from here, as I said earlier, we're trying to augment our hospital avoidance. So with COVID, that's been really helpful because there's new initiatives being welcomed rather than being resisted. But we actually need the legislative change for that to happen. So yeah, we're still onwards and upwards from here.
Thanks very much, Mel. That was fantastic. Thank you very much for taking your time to present to us today. As mentioned earlier, guys, if you have any questions, just pop them into the chat. But I might just start off, Mel, regarding prescription and imaging referral, etc. You touched on that at the start of your presentation, and of course you're studying your Masters at Deakin University that does have a unit of competency regarding prescription as well. When we do get have political change and legislative change to allow paramedics to access that. My question with regards to that is, in the future, with prescribing paramedic practitioners, do you see a role for that within the ambulance service, or do you predominantly see a role for that in primary care settings or other community settings where paramedics are more widely employed? What is your thought on that?
I think it can be in both, to be honest. I do see a scope, given what we're doing a lot, to be able to, at the moment, we'll go out to a patient and we will dispense medications under the auspices of the CMO, etc. So antibiotics, antispasmodics, we have a very large drawer full of medication. So there's a lot that we carry, but to be able to go in, do that autonomously. One of the biggest areas is within the RCF. So nursing homes, quite often, patient has a chest infection or a UTI or some kind of infection, needs an antibiotic. We can go and give the antibiotic. We can leave the antibiotics there, or they've got it in impress. There's no one to write up the script. So they've got to get in a locum, and locums are just not going out at the moment, and they don't have a good system for, getting faxed referrals and things like that. So within an ambulance service, to be able to go in and write up pain relief and antibiotics and make medication changes on a drug chart within the ambulance service scope, we'd be able to keep quite a few more patients out of hospital. When it comes to community, I think given the lack of locums, particularly in metro fringe and rural and remote areas, there's just no limit to what can be done. One of the other roles we do fulfill sometimes is going up to the country hospitals, the quite rural and remote hospitals, where they can't get locum coverage for a weekend, and we are the doctor and essentially the proxy doctor in the ED on a weekend. So we can do pretty much everything, but we can't prescribe the meds that they need to go to the pharmacy and manage at home. So having it within that context also really good. And I see one area for paramedic practitioners in that role in community, either independently or attached to an ambulance service, it wouldn't matter, preferably independently, because that would be really cool. But doing that locuming within the rural and remote area EDs, so that these GPs who are flogged all day in their practice don't have to come in at night and don't have to come in all weekend and then work all day. They get some work-life balance back. We might actually get a few more going regional. We might actually get them staying regional a bit longer if we've got a way of supporting them better outside of normal business hours when they're already putting in such long hours. So and the patient who's discharged from hospital after presenting to an ED but hasn't been to see their GP or specialist since, that little window is just so dangerous. It's probably the most dangerous time frame. So if we could have some influence in that space, I think there's a really massive role there too, with or without prescribing rights. And my little PhD project as well is kind of exciting, with a code and off pathway that involves no ED presentation at all, straight to theatre from a nursing home. So yeah, which could be exciting. So see where that one goes. But yeah.
We've got a couple of questions from the people online here. So I'll start with Naomi, who said that you guys are far beyond the scope of practice of the LARU or ECP paramedics in Queensland here. And she's asked if, in fact, it's split into two. There was one underneath this. So do you need to be an ICP to do the internship? And has your scope of practice been driven by your medical officer?
Our scope of practice is driven by us a lot. Like initially it was by the medical officer, but we are quite a passionate bunch, And so we just keep pushing. We're the ones, all the pushing is coming from us to improve our scope and broaden our scope. And the more fresh blood we get in, the more ideas we get. And we've got some who are really passionate about palliative care, some who are really passionate about wounds, plastering, that sort of thing. So everyone's got their passion, and we're using that passion to push our scope. And we've got a new CEO, and we've now got a new government. So yeah, I think we are onwards and upwards from here and can actually push even further. We do have community paramedics as well, who are also intensive care paramedics, but not necessarily ECPs, who do the more traditional community paramedic role. But their scope is not the same. They don't do catheters, they don't do suturing, they don't do a lot of those things. They just go and do the dressing changes, sort of more of a community nursing with the paramedics mindset in applying those skills. So it's a little bit better. So yeah, it's a bit different, and they have to be ICs as well. The original plan, when Angela Martin wrote the program, was that paramedics would be doing it, not ICs, in the community paramedicine role. There has been a whisper of splitting off the ECP role to, the actual tactile skills, some of the tactile skills that are just, go and change a peg, go change a catheter, go change a wound dressing, might go to a paramedic level. And then the IC ECP would do, the version 2.0, the higher end sort of palliative care and prescribing and all those other things as well, and the suturing and stuff. So I'm not sure, there's been whispers over the years, but nothing's ever come of that so far.
Sorry, I'll turn off my microphone. Thank you. Nicole has got a question here. At the very start, she said it was a wonderful presentation and thanks. Very impressive scope of practice. Can you please expand on what your 6-month internship involves? And is there structured mentorship from other ECPs?
So with the 6 months, that includes your didactic component. So you do some time up in comms, learning how to use all the computer system up there and learning the ropes. And I can tell you, one of the biggest things I had to learn was what is in the RFDS box at the back end of some farm somewhere in the middle of the boondocks. Like, what have they got in that box to cope with a situation? It's actually amazing. It's really quite frightening telling someone to give IM morphine in large amounts over the phone to someone who's not medical. It's really bizarre. But yeah, so they have that component. And then you have the senior ECPs will take on an ECP intern, and we just ride along together, and they do all the work that they can to get the experience. Like, we obviously work together, but it's not job about like you would, in a normal truck situation. You try and give them as much scope as you can, as much leash as you can to get as much learning as possible in that time. The good thing, I think, with the ECP role is it's a completely different mindset as well there to the other clinical roles, in that it's far more collaborative. Like, we will call each other, we'll call up in the room and go, this is what I've got, this is what I'm thinking. Can we just sanity check that one? And it works really well. It's a really good system to have that level of collaboration. So yeah, that's kind of how it works. So you never really feel completely alone.
That's fantastic.
And quite often it's okay to ring up and go, you want me to go and what? Because some of the stuff you get sent to you go, oh, hang on a minute, you want me to what? Are you for real? And yeah, there's some really insane stuff that we've done, and it's awesome.
It's awesome.
Yeah.
Adam has just mentioned, I don't know if there's a question in there, but I'll read out the comments anyway. He just wanted to say thank you for your presentation. He's a specialist paramedic in the UK, and there are lots of similarities between the roles, and prescribing for them over in the UK has made a big difference. And although it currently does not have any controlled drugs, they're limited in areas such as palliative care, but he's also working on his PhD in this area to see if paramedic prescribing in emergency and urgent care settings can be valuable. So there's some experience there from overseas to say that prescribing has made a difference to practice. And yeah, it's going to be very, I
think I need your email, Adam.
Yeah, it's going to be really exciting.
Awesome.
it's going to be really exciting to see the space and prescribing into the future here, not just in ambulance services, but the role for paramedics working in all sorts of different areas as well, which is just fantastic.
It's so exciting. I've recently done one of my placements with the doctorate, and I was working down at Victor Harbour, down on the Fleurieu Peninsula, and I was in one of the medical centres there, and oh my word, like Medicare really needs a kick in the pants to fund properly so we can get primary healthcare right. But I absolutely loved it. Just the stuff that we were doing is just amazing, and they could see a role for a paramedic practitioner in their practice, you know, even just in wound management, both acute and chronic, and wound like excision of lesion and some of those other things that, you know, the doctor could oversee, but the paramedic practitioner could actually be the one to do them because we've got the skill set. But there's just no way they can get funded for it unless they actually do it themselves. And that's going to be one of our limitations. And until that changes, you know, until we get a provider number and can charge for some of these things, we're not going to be as economically valuable. However, that being said, we are still going to be valuable in the sense that they can see more patients in the time that they're currently being constantly interrupted. So, yeah.
Yeah. Well, thank you very much, everybody. I can't see any other questions. If there are, you can go and pop them through just in the next couple of seconds, I guess. But I wanted to say thank you again to Mal for being part of this presentation today. That was a really fascinating presentation and a really good deep dive into what ECPs in South Australia are doing at the moment. And it looks like there's some really fantastic envelope pushing skills and thinking that is occurring in this space, and just fantastic. So thank you very much, Mel. Thanks everyone for participating.
I'm just putting my email address in the chat. So if anyone wants to chat more, particularly for Adam as well, if anyone wants to chat more about the ECP role, if you are keen on coming to South Australia to be an ECP, please, we need more. That would be great. But yeah, just, I'd love to touch base with Adam, especially just to chat more about how things have changed over there and the efforts they went to and how we can maybe do a multi-centre trial of some sort. So yeah.
Perfect.
Excellent.
Thank you, everybody. I hope you all have a good evening. Take care.